Good evening, everyone.
Sir, please start. Yes, thank you.
Good evening, everyone. I am Dr. Sachin Patil, MAHAIAP Executive Board Member from Yavatmal, along with Dr. Ravindra Sonone, sir, Treasurer MAHAIAP 2025. It's my pleasure to welcome you all on this third episode of Friday Punch series, that is the Friday Ka Punch MAHAIAP Ke San, one of the academic activity of MAHAIAP 2025. Tonight, we have assembled an exceptional panel featuring 5 distinguished speakers along with the 2 eminent experts. And today's topic is pediatric hematology updates. We are thrilled to share our knowledge, insights, and experiences with you. Let's make this session informative, interactive, and memorable. It's my privilege to, on this platform, to wish the respected Dr. Sanjay Pakmode sir the birthday wishes. So happy birthday to our respected MAHAIAP President Dr. Sanjay Pakmode sir. We wish you a plenty of joy today and every day of the coming years. You are a perfect example of wisdom, leadership, and foresight. On your birthday, we wish you peace, good health, and happiness. So please accept on behalf of all the delegates and all MAHAIAP team the birthday wishes, sir. Now I request you to give us the welcome address. Over to you.
Namaskar. Namaskar. Good evening. First of all, thank you, Sachin, for your kind words. And it's really a great thing on my birthday there is a Friday Ka Punch. That is one of the MAHAIAP academic activity. And that too in the presence of 2 experts, out of which one is my guru, Dr. Dipti Jain ma'am, with whom I worked in UG days and PG days. And another expert, the Swati Kanakia madam from Mumbai. And all the 5 presenters and our 2 moderators, Dr. Sachin and Dr. Ravindra. Now, this our Friday activity, Friday Ka Punch MAHAIAP Ki San, is a wonderful. Every time, every month, we alternate month we conduct such these activities, and we select one of the system. So this time we have selected the hematology topics, and all the 5 topics are very routine in our practice. So most of the things we knew, but let us hear from the presenters as well as from the experts something new regarding this topic, and which will help in practicing in day-to-day practice, and which will enlighten us and add to our knowledge. So I welcome you all on this wonderful platform of MAHAIAP, and I welcome today's expert Dipti Jain ma'am, Swati Kanakia madam, and then our MAHAIAP treasurer Dr. Ravindra Sonone, then our scientific in charge Dr. Minhaj Sheikh sir, then convener Dr. Sanjay Deshmukh, then Vice President Dr. Pankaj Agrawal, and Women Wing Chairperson Dr. Jaya Shivalkar madam, and all the today's attendees. I could not see Amol and our dynamic secretary Amol, and all today's attendees, and I welcome you all on this wonderful platform of MAHAIAP, and I think everybody will be will be added to their knowledge, so that let us hear from our presenters as well as from the experts regarding the today's topics. Over to you, Sachin.
Yeah, thank you, sir. Your words are always inspirational for us for our academic journey. Dr. Amol sir, are you there? Amol Pawar sir, join नहीं ऐसा वाटता.
No, sir. No, sir.
अमोल ट्रैवल तो नहीं कर रहा है. He must be traveling.
Now I request Dr. Sanjay Deshmukh sir, our convener, for the welcome address. Over to you,
Good evening.
Deshmukh sir.
Firstly, many happy returns of the day, Dr. Sanjay Pakmode sir, and we wish you many more healthy years ahead. as a MAHAIP convener, it's a great opportunity for MAHAIP ones to have Friday Cup brunch in every month. And hats off to our scientific chairperson, Dr. Meena Sheikh sir, the today's moderator, Dr. Sachin Patil Bhau, our dynamics treasurer, Dr. Ravindra Sonoy sir. And we are very happy and honored to have expert like our guru, Dr. Dipti Jain madam from Nagpur, and Dr. Swati Kankani ma'am from Mumbai to moderate this session. Hematology is a very difficult topic and rightly chosen by our scientific team. All the topic they have selected very nicely. And I'm very happy they have selected hemophilia also in this. 17th April is the World Hemophilia Day. Since last 10 years, I'm working in Nagpur as a hemophilia day care in charge. Dr. Bhutada ma'am is also a hematologist. Unfortunately, hemophilia, though rare, but it's so common nowadays. And I am happy you have taken this topic. So I wish all the best to all the dynamic faculties, Dr. Amol Karangale, Dr. Prasad, Dr. Snehal, Dr. Anna Sahib, and I wish all the academic happy journey on this MAHAIP platform. Thank you. Thank you very much.
Ravindra sir, over to you.
Yes, thank you, Sachin. So very warm welcome to all the dignitaries, distinguished experts and speakers and delegates and participants joining us for this insightful webinar on advancement in pediatric hematology, organizer under the esteemed banner of MAHAIP 2024-25. It is both an honor and privilege for me, along with my esteemed co-moderator, Dr. Sachin Patil, to facilitate today's session. We extend our deepest gratitude to Dr. Sanjay Patmode, MAHAIP President 2025. And also I wish him many happy returns of the day. And Secretary, Dr. Amol Pawar, Convener, Dr. Sanjay Deshmukh sir, and Scientific Convener, our teacher, Dr. Meena Sheikh sir, for entrusting us with this opportunity and for their visionary leadership in advancing pediatric care in Maharashtra. Today, we have a stellar panel of experts and speakers who will share groundbreaking insights on hematological disorders in children. So, I take my privilege opportunity to introduce our esteemed expert for today's webinar, Dr. Dipti Lalit Jain madam, who is my mentor and my PG guide also, a renowned expert in the field of hematology with special focus on sickle cell disease. Currently serving as a director of Arihant Super Specialty Hospital in Nagpur, she brought over 3 decades of experience in pediatric and hematological care. She has also been nodal officer for the prestigious CSIR Sickle Cell Mission Mode project since 2015, which played a very pivotal role against sickle cell anemia. Her academic excellence includes MD and MSc in medicine from McMaster University, Canada. She has held leadership positions as a professor and head at Government Medical College in Nagpur, Akola, and IGMC. She Rockefeller Fellow. She has contributed as a Rockefeller Fellow. She has contributed globally as an advisor to the Global Network for the Sickle Cell Disease and as a co-editor of Lancet Hematology Commission on Sickle Cell Disease 2023. Currently, she chairs the task force towards the elimination of sickle cell anemia in India by 2047, a flagship initiative of the Government of India. Her works bring research, policy, and grassroots implementation, making her a true pioneer in this field. So we are honored to have her share her insight with us today. Please join us in extending warm welcome to the Dr. Dipti Jain madam. I request and welcome madam to say a few words. Welcome Dr.
Thank
Dipti
you,
Jain
Ravi,
madam.
for your kind words. And it's really a pleasure to have all my students here doing so well. They are all in big positions. Dr. Pakmore, Dr. Sheikh, Dr. Ravi, Sanjay, all of you. And I'm happy that you have taken very good topics today, all the topics which are we deal in day-to-day practice. So I think that's all we'll discuss as the program goes on.
Yes.
Thank you.
Thank you, madam. Now, I introduce our second expert, Swati Kanakia, madam. She is a pediatric hematologist, oncologist with special interest in primary immunodeficiency disease. She has extensive experience in treating children with acute leukemia, solid tumor, Wilm tumor, neuroblastoma, hepatoblastoma, brain tumor, anemia, thalassemia, iron deficiency anemia, hereditary spherocytosis, sickle cell disease, ITP, platelet disorders, bleeding disorders, and repeated infection and autoimmune disease, etc. She also consults patients regarding bone marrow transplant. She administers chemotherapy. She also does bone marrow aspiration biopsies and does all the sports. She is affiliated to Lilavati SRCC and Shushruta Hospital. She is available for consultation at Dadar with prior appointments. I welcome Madam Swati Kanakia, Madam, and request to say a few words. Welcome, Swati, Madam.
Thank you, Dr. Sonambi, for your kind words. It's indeed a pleasure to be on the same platform as Dr. Dipti Jain. I am very, very delighted. And I must thank Dr. Sheikh for inviting me for this session. And yeah, it's going to be fun. I'm very happy to see Shraddha on this panel as well. She was with us at Lilavati, and it's really a pleasure to see her. Thank you so much for the invitation.
Thank you, madam. Now, I will introduce all 5 speakers. First is Dr. Shraddha Chandak. She is pediatric hemato-oncologist, immunologist from Cape Pond Super Specialty Hospital, Chhatrapati Sambhaji Nagar. She is having 19 years of experience in treating blood disorders and cancer. And she is also having this Happy Kids Foundation, which has supported countless pediatric cancer patients. She has done MBBS, DCH, and DNB, and with fellowship in pediatric hemato-oncology and immunology. I welcome the Chandak madam. Now, second speaker is Dr. Prasad Prabhakar Dham. He is pediatrician. He is consultant. He is working in Sadak as a owner, Sadak Child Care Hospital in Dharashiv, Usmanabad. With a patient-centric approach, he specializes in general and critical pediatric care, ensuring the well-being of the children in the region. Now, I welcome Dr. Snehal Killedar Patil. She is PISU consultant working at Masai Hospital, Kolhapur. With qualification including MBBS, DCH, and IDP CCM. She brings expertise in managing critically ill children, ensuring life-saving care in high-pressure environments. Now, I welcome fourth speaker, Dr. Anna Saib Lokande. He is DNB Pediatrics and also PISU Fellow, and he is in consultant in Naujivan Bal Rugnalay, Solapur. He specializes in managing severe childhood illnesses and emergencies. And our last and fifth speaker is Dr. Amol Karangale, consulting pediatrician at Karangale Children's Hospital, Katol, Nagpur. So I welcome our 2 experts and 5 speakers. So together our distinguished panel brings a wealth of experience in pediatric hematology, oncology, immunology, and critical care. Let us give them all a warm welcome as we begin this insightful session. So I hand over mic to the Dr. Sachin Patil. Thank you.
Hello, sir. Now I think our HSD Dr. Amol Pawar sir has joined. I request
Yes, sir. Amol sir
Dr.
has
Amol
joined.
sir. Sir, join झाले ते.
I'm there.
Yes, sir. Amol sir, please.
Yes.
Give us welcome address. 1 minute.
So I'm here at Rajahmundry. Central Zone Pedicon is there. So already I written in the chat box. I welcome everybody's mentor, from Vidarbha region, Dr. Dipti Jain ma'am. We when last year this MAHAPedicon was there, we went for inaugurating one workshop which was conducted at her hospital, and it was very properly managed workshop. And so welcome, respected Swati ma'am. Dipti ma'am. Then second expert from Mumbai, MMR, Dr. Swati Kanakia ma'am. Welcome to Swati ma'am also. And I welcome all the 5 speakers from various districts of Maharashtra. Dr. Snehal, Dr. Swati, Dr. Anna Sahib, our Maharashtra IP Executive Board member, and Dr. Prasad sir and Dr. Amul. And also
Sir,
so I wish a very happy birthday to our member, Dr. Amruta Shirukar ma'am. I will not take much time. Wish you all have a HOD at Nasik Medical College, and also my friend Dr. Sachin Patil, who is tirelessly working very hard for the success of this Friday Cup Punch Maharashtra IPK Sangh. He happens to be executive board member of Maharashtra IAP also. So thank you, Sachin and Dr. Ravindra Sonane sir. Please proceed.
yes, thank you, Amol sir. Now I request Dr. Shraddha madam to start your lecture. The topic is hemophilia management overview. Over to you, Shraddha ma'am.
Good evening, everyone. First of all, I would like to thank all MAHAIP platform for giving me opportunity to be here. And I'm very happy, I'm very delighted to present my talk in front of my 2 great teachers. And that is just like you all, Dr. Dipti Jain was my mentor, my guru, and I still admire her. I look upon her that even I'm trying to be like her. And Dr. Swati Kanakia ma'am, my teacher at Leelavati. So very happy. At the same time, I'm nervous also. So actually today's my topic is hemophilia overview management. Let me tell you, the hemophilia topic is not that short that I will finish the management in 8 minutes, but I will try to cover maximum point with this time. Before I start my topic, I would like to thank all my teachers, my friends, my colleagues, all the sisters from whom I have learned so much, and because of whom today I am here. So let's begin with our hemophilia topic. So the most prevalent hereditary disorder of coagulations, all of we know that it's von Willebrand hemophilia A because of factor 8 deficiency, hemophilia B because of factor 9 deficiency. Now, these are the most prevalent, as well as because of the techniques and investigations, we are diagnosing more and more cases nowadays. But problem in our country is low level of awareness, lack of diagnostic and treatment facilities. All of us, we know that hemophilia is transmitted. It's a genetic disease. It has an X-linked inheritance. That is, the females are carrier and affected person are male. So the carrier mother and a normal father, there are chances that the 25% the female will be carrier, 25% the newborn will be affected male, 25 and 50% chances will be normal male or female. So it's all completely genetic. Females are carrier and males are affected one. The diagnosis of hemophilia, it's based upon the some clinical features like easy bruising in early childhood. It is suspected when child starts crawling, generally at 9 months of age, and when he just bounces at some furniture or falls down, and he develops big hematoma, and which is not resolved, or it's a delayed bleeding. Spontaneous bleeding, particularly in joints and soft tissue, excessive bleeding following trauma or surgery, and when there is a positive family history, like when we ask, especially to the maternal side, कि मम्मी का भाई, आपके मामा के बच्चे, लड़कों को कोई प्रॉब्लम है क्या, ब्लीडिंग डिसऑर्डर है क्या, जिनको पीला खून चढ़ाया जाता है, and generally we get the answer. So these are the clues when we suspect hemophilia. Investigations, Very commonly, whenever child comes with bleeding, we ask for CBC, coagulation profile, and peripheral smear. So generally CBC platelets are normal. Prothrombin time is normal, but when APTT, that is activated partial thromboplastin time, is prolonged, and especially this prolonged time is like 120 seconds, 140 seconds for the control of 30, that is the time when we should think, are we dealing with some factor deficiency? And when we do factor assess, especially factor 8, factor 9, and we get the reduced level. So reduced level is like just 1%, 2%, less than 1%, that is hemophilia. So depending on the factor level, the level of factor, we classify the severity of hemophilia, that is mild, moderate, and severe. So when factor level is less than 1%, it is known as a severe hemophilia, and the patient presents with spontaneous bleeding, predominantly in joint and muscles. The moderate hemophilia, when activity is 1 to 5%, and there is occasional spontaneous bleeding, but the severe bleeding with trauma or surgery. And the mild hemophilia, when factor activity is 5 to 40%, that is the severe bleeding only with major trauma or surgery. And the symptoms and treatment, they all depend on the grade of the severity of the disease. The clinical features, as we know, we get a characteristically deep internal bleeding, usually spontaneous or following minimal trauma, and delayed bleeding due to the failure of secondary hemostasis. The sites of the bleeding, generally we get the bleeding in the joints, major joints like ankle, elbow, knee, the muscle, soft tissue, mouth, gum, nose, epistaxis, and hematuria. But life-threatening bleeding sites where we are very much worried, that is when there is bleeding in CNS, intracranial hemorrhage, subdural hemorrhage, gastrointestinal bleeding, neck or throat bleeding, or whenever there is a severe trauma or accidents. So these are the patients, like wherever there is a neck muscle hematoma and we can see the large bleeding, and the patient has been done with tracheostomy. The frequency of bleeding, the most commonly what we get is the hemarthrosis, that is bleeding in the large joints, and that is 70 to 80%, followed by the muscle bleeds, that is 10 to 20%, and then other major bleeds, CNS bleed is less than 5%. So these are the clinical manifestations. Characteristically, these are the hemophilic knee joint or arthropathy, and this is like a pseudo tumor. If we can see this child, there is a hematoma behind the orbit. So these are the bleeding sites, the muscle bleeds. Now the principles of the treatment of hemophilia. Now the major treatment, hemophilia is a genetic disease. It's a inherited disease. So it's not a one-time illness like typhoid and malaria. So there is no medicine that it will cure hemophilia. But the aim is to improve the health and quality of life. That is most important. So prevention of bleeding with prophylactic treatment, long-term management of joint and muscle damage, the management of complications from treatment, which includes even inhibitor development, and transfusion transmitted infection. So these are the 4 principles on which our treatment depends. We don't have to treat hemophilia per se, but we have to treat the person and his family who is affected with the hemophilia, because there are multiple facets like physical, emotional, psychological, educational, financial, and vocational factors which are affected, which are disturbed because of the one illness, not only of the patient but of the entire family. So whenever patient with hemophilia, we get multiple modalities that we need to involve in the treatment. It's not only the me who is going to cure the hemophilia, but along with me, with hematologist, general pediatrician, who is the first contact of the child, orthopedician, if there is a fracture or there is a muscle bleed or a joint bleed, nursing care, genetic counselor, dentist for the any dental problems. Then we need to have the availability of the factors, which is the mainstay of the treatment. The primary care, psychosocial support, physiotherapy, and social workers. All these team, that is the mainstay of the comprehensive care of hemophilia. The treatment, first, it depends on the accurate diagnosis. So first is suspicion, investigate, make an accurate diagnosis of whether are we dealing with hemophilia A or hemophilia B. Then followed by the specific treatment and general measures. So let me tell you, once you diagnose the child with hemophilia, first thing is to give him an identification card, which will have his name, his address, emergency phone number of parents, Hemophilia Society, treating physician, and his blood group, which he will be carrying all the time. So whenever there is any major incidents or accident, anyone can know that he needs, it's like an emergency case and he needs immediate medical attention. Whenever there is a fracture, the first thing, like this is for my orthopedician friends, like first to give factor, then to apply cast. So that is the one thing which we need to remember for the hemophilia. Basic management in case of any emergency, because any bleeding is emergency for any parents and any doctor. So what we need to think first is ABC, that is vital stabilization, airway, breathing, circulation, followed by venous access, appropriate investigations, factor replacement, inhibitor screen, inform nearby Hemophilia Society to make the factors available as early as possible, arrangement for the factor dosages, avoid intramuscular injection, monitor factor 8 and factor 9 levels, and appropriate long-term treatment. So these are the basic principles of management of hemophilia. So what we should avoid in hemophilia, it is avoid intramuscular injection, all contact sports, aspirin and NSAIDs as far as possible, difficult phlebotomy or arterial punctures, and trauma by any adjusting their lifestyle. So we should advise patient to follow that lifestyle where the trauma will be minimum. Then what to do? Ice application at site of bleed whenever there is a bleeding, early factor correction, all procedures to be done under appropriate factor cover, immunization, regular exercise should be encouraged to promote strong muscles, protect joint and improve fitness, dental hygiene, and ongoing counseling and education. Remember, the counseling and education, it's not one point job. It should be continuously occurring, because every time patient will come with new query and we have to solve it. Physical activity, we generally advise to avoid all contact sports. Whenever child starts school, we have to inform their principal or class teacher that child is having bleeding disorder. So avoid all sort of physical punishments and take up the recommended games only. Immunization, yes, every child immunization is a basic right of every child, but for hemophilia, we should not give injections into muscle. Rather, we should give subcutaneously, followed by firm pressure applied to the injection site at 10 minutes, and we should avoid giving factors before any vaccination. Now, the most important, what we are concerned for hemophilia is hemophilic arthropathy, because as we have seen, 90% patient bleeds into the joint. So it's a acute bleed, subacute bleed, chronic synovitis, chronic hemarthrosis is most common, most painful, most physically, economically, and psychologically debilitating and disturbing, and it occurs in 90% of hemophilia. So whenever child present with acute hemarthrosis, we have a swelling, restriction of movement, tenderness, and shiny skin. So treatment, so what we have to remember is the price. So P for protection, R for rest, I for ice application, C for compression, and E for elevation. So we have to protect the joint by avoid the extra movements, give rest, give ice application, proper compression, and give elevation. Followed by the next symptom is like a pain, which is very disturbing pain, and we have to address that pain issue, which is most commonly neglected in hemophilia patients. So for pain management, we have multiple analgesic we can choose as per the tolerance of the patient. Then venous access. The most importantly, venous access should not be done at injured or affected limb. That is the point we need to remember. So if I have a right elbow joint swelling, I should not be putting the IV line at right hand only. So I should use any other 3 limbs. No jugular or femoral access unless it is life-saving emergency. Then the next is definitive treatment, that is clotting factor concentrate treatment replacement, which is the mainstay. So it can be on-demand therapy or episodic and prophylactic therapy. So what are the CFC, that is clotting factor concentrate available? Either they are plasma derived or recombinant. So low, intermediate or high purity plasma derived, but nowadays recombinant first, second or third generation, which are long acting factor concentrate, which are used most commonly. So the first generation and second generation, these are animal and human derived proteins. What is the difference? In first generation, the preservative is albumin, and in second generation, instead of albumin, we use sucrose, but which is used as a stabilizer. But in third generation, no animal, no human plasma derived proteins are used during production. So these are the factors. Now the dose of the factor. So each unit of factor 8 infused per kg body weight yields 2% rise in factor 8 level. So in hemophilia, we have to give factor 8 infusion. The dose is calculated by this formula: desired level minus patient level into weight in kg into 0.5. And the biological half-life of factor 8 is around 8 to 12 hours. While in hemophilia B, we have to replace factor 9. Each unit of factor 9 yields 1% rise in plasma factor level. So the dose is desired level minus patient's level into weight in kg. So here patient's level we always consider is negligible, either 1% or 0%. So whatever we need a desired level like 40%, 60% into weight in kg into 0.5 for factor 8 level, that is are the dose which we need to give. Other pharmacological options like desmopressin, antifibrinolytic agent, tranexamic acid, or epsilon aminocaproic acid. But remember, these are the temporary. The mainstay is factors. The use of desmopressin. Now, desmopressin is synthetic analog of vasopressin, which increases the 3 to 5-fold rise in factor 8 level. Okay, and it is used in mild to moderate hemophilia. But response is variable. It has a transient flushing and headache as a disadvantage. There is a tachyphylaxis, which is major limitation of factor and contraindicated in patient with hypertension or coronary artery disease. So the dose is, it's an intranasal spray, 0.3 microgram per 300 microgram intranasal, and IV is 0.3 microgram per kg. It increases factor level within 60 minutes and the effect lasts for several hours. So the next is chronic hemophilic arthropathy. Now, when joint bleeding occurs frequently or repeatedly, it goes into the chronic arthropathy. Now, what is this? This is a normal joint. Whenever bleeding occurs in the synovial fluid, the synovial thickening is occur. Synovial fluid thickening is inflamed, and there is lot of fibrosis and restrictions of the movement of the joint. So, what is target joint? So target joint means the hemophilia has targeted one particular joint. So when we say that 3 or more spontaneous bleed into a single joint within a consecutive 6-month period, that is known as a target joint. So these are the target joint, and we see lot of such patient in our daycare hemophilia center. So the management of chronic hemophilic arthropathy, conservative management, that is factor replacement, immobilization, gradual supervised physical therapy, and synovectomy to control bleeding and prevent progressive destruction of articular cartilage. Again, the type of synovectomy, either conventional arthrotomy or the arthroscopic synovectomy, or a non-surgical synovectomy like using chemical like rifampicin or radioactive material. Then the dose of the clotting factor concentrate. So as I said, for hemophilia and hemophilia B, what is the type of hemorrhage? That so duration and dose depends on the type of hemorrhage. Like if we have a joint or muscle bleeding, we need to raise the factor level up to 60%. But iliopsoas muscle bleeding, we need to factor level up to 80 to 100%. Same for the CNS, neck and throat bleeding or GI bleeding, and the duration varies depending on the site of the bleeding. Chronic complications of hemophilia is 2 types, because of hemophilia and because of treatment. So musculoskeletal complication, as we see, chronic hemophilic arthropathy, chronic synovitis, deforming arthropathy, contractures, pseudotumor formation, and fractures. While because of treatment is the inhibitor against factor 8 and factor 9, and TTI, that is transfusion transmitted infections like HIV, HBV, SCV, HAV, or parvovirus B19. Now the joint bleeding. Then like these are the joints what we see, and this optimal therapy can prevent such occurrence, deformity, and chronic complications. These are the pseudotumors. Prophylaxis. Now what is prophylaxis in hemophilia? So treatment by intravenous injection of factor concentrate in anticipation of or in order to prevent the bleeding. So we are giving the factor before any bleeding occurs. So what are the goals in prophylaxis? Is to keep the factor 8 level above 1% all the time. In short, we are trying to convert severe hemophilia into mild or moderate hemophilia. So to prevent the bleeding into large joint, to prevent life-threatening bleeds, and what are the long-term goals of prophylaxis, which are more important? That is prevention of life-threatening bleed, prevention of chronic disease like target joint, improve the quality of life, and reduction in long-term social cost of individual. Again, there are 3 types of prophylaxis, either continuous prophylaxis or intermittent prophylaxis. So continuous is defined as 52 weeks per year. That means almost every week you are going to give factor 8. So there are again 3 subtypes, primary, secondary, tertiary. So primary prophylaxis is started before any bleed sets in or before any joint disease which is documented clinically or radiologically. Now, secondary prophylaxis is regular or continuous treatment after 2 or more bleeds into a large joint, but before joint disease has settled, right? And the tertiary prophylaxis, that is prophylaxis which is regular, continuous, that we start after the onset of joint disease, which is documented clinically and radiologically. While intermittent prophylaxis, that is periodic prophylaxis, it is the treatment given to prevent bleeding for period not exceeding 45 weeks in a year. So advantages of prophylaxis, that decreased or to absent bleeding, minimal to reduce joint damage, greater activities in sport participation, normalize life and social and family life, and minimizes school or job absentees. So there are various prophylaxis regimens like Malmo, Utrecht, Canadian, where there are different doses, different interval, and there are different like time interval that when we need to start. Now, all these prophylaxis, they occur, they are routinely carried out in foreign countries, but India, it is still our dream because of the cost constraint. So home therapy. Now that this is something which is very important. We can teach our educated parents that how to give or how to infuse factor 8 at home. What are the advantage? Because it's a small scalp or needle that we need to insert in vein, and we have to infuse the factor 8 with proper dilution if we teach our parents properly. So there is less pain, less disability. That is the advantage. Fewer hospitalization, less time lost from school or work. They don't have to take leaves from their job. Improved quality of life and independence. There is one more concept of a satellite center in hemophilia management. Like for the interiors of the patient who cannot go to all the way to taluka place or a district place. So in between, we have we identify the satellite center where primary, either these are the PSCs or dispensaries or hospitals, which can give factor 8 to this identified patient. Now, the main our concern is the inhibitors. So though our newly recombinant, advanced, all factors, they are very much efficient, they are very much safe, all we know, but they are still immunogenic. We have not got the answer to lessen their immunogenicity. So when anti-hemophilic factors are in sufficient amount to treat the patients, still our fight is against the inhibitors, and it is difficult problem to manage the inhibitors in hemophiliac patient. So incidence of inhibitors is around 10 to 15% hemophilia A and 2 to 3% in hemophilia B. So these are the factor 8 when we infuse to a bleeding patient. Inhibitors, they bind to factor 8 and they inhibit factor 8 to reach at the bleeding site, and patient keeps on bleeding even if we infuse the inhibitor. So that is what inhibitors role is there. So when we should screen for inhibitors in children, once every 5 exposure days until 20 exposure days, or every 10 exposure. Now, what is the meaning of this line? It might be confusing. So once every 5 exposure. So for first 20 doses of factor 8, we need not to worry. But after 20 doses, when we give next 5 doses, like up to 25, we need to screen for inhibitor once. This is the theoretical or ideal. So every 10 exposure days, between 21 to 50 exposure days, at least 2 times a year until 150 exposure days. And for adults, more than 150 exposure days. Failure to respond to adequate factor concentrate replacement, patient who have been intensively treated for more than 5 days and prior to surgery. So no inhibitor screening is must to prior to surgery, that is the must investigation in any hemophiliac patient. So they are high responding inhibitor, low responding inhibitors. I'm not going in detail because time is constrained. So for high responding inhibitors, we have activated PCC like FIBA and recombinant activated factor 7, that is Novo-7. And for low responding inhibitors, we can give factor dose in higher concentrate, like 2 to 3 times the required dose. So management of inhibitors, so first you have to screen higher doses of factor 8, 9, bypassing agent, as I said earlier, and duration to maintain the circulating factor level above 50% at all times up to 3 weeks following CNS bleed. So precaution in treatment of hemophilia: to avoid any elective surgery before 50 exposure days, avoid clotting factor concentrate during vaccination, to avoid factor before 6 months of age, to avoid intensive treatment before 50 exposure days if possible, and to start prophylactic treatment. Prevention: prevent the birth of hemophiliac child. That is the mainstay of the prevention with the prenatal diagnosis, counseling, and continuous education of the parents. So take home message: what we need whenever we suspect hemophilia, we need first accurate diagnosis, education of patient and relatives, prompt replacement therapy with required factor, which is the mainstay of treatment, home therapy, replacement education that we need to teach to the parents, early physical therapy to be instituted as soon as acute hemarthrosis subsides to improve the quality of life, regular exercise program, and prophylactic therapy whenever possible. With this, thank you so much for patient listening, and thank you once again. Thank you so much, MAHAIAP platform, for giving me this opportunity. Thank you so much.
Thank you, Shraddha ma'am. Really, it was a very informative talk. Please stop sharing that. Now, I request Dr. Dipti Jain ma'am for your expert's comment.
Thank you, Shraddha. You have described most of the common management for hemophilia. Can you tell about something about non-factor therapies, because we have some postgraduates in the audience? So
Yes,
I think, yeah.
Yeah, so in non-factor replacement, whenever there is, so we have a cryoprecipitate, which has factor 8, factor 9 concentrates. Then if not cryoprecipitate is available, we can give FFP, that is fresh frozen plasma, in case of emergency, because emergency treatment is must, the life come first and then our theory knowledge. Then there are some drugs, like as I have mentioned, that is tranexamic acid, epsilon, like whenever there is epithelial bleeds, we can give the application of tranexamic acid locally, like nasal bleeds or gum bleeds. Then epsilon aminocaproic acids, as I mentioned. So
Shraddha,
that
actually, I'm talking about monoclonal antibodies now.
okay. Sorry, ma'am, I won't be able to tell that in detail. Actually, frankly speaking, I have not gone or revised that thing at present, and I am having my train at 10 o'clock.
Okay.
Yeah, I
Okay,
need.
thank you, Shraddha.
Let me interrupt here.
Yeah, please.
Shraddha, thank you so much. I think it was a wonderful talk. You took us through all of the hemophilia. Ma'am, to answer your question, so the antibody you're talking about is emicizumab,
Yes.
which is a bispecific antibody. And if you remember the coagulation cascade, factor 8 acts between activated factor 9, that is 9A, and it acts on 10, and then you go down to the common pathway. So this emicizumab actually kind of replaces factor 8, so to say, and it joins these two factors, and there is generation of thrombin. Emicizumab is an expensive drug, as would be expected. However, it's very good to say that government is now giving emicizumab free in Tamil Nadu. Some time ago, couple of years ago, in fact, I had a patient from Sri Lanka, and the Sri Lankan government is also giving emicizumab for free. It is available in India as Hemlibra, and it is available in different strengths. What we have done at, let us say, at KEM Hospital and at Wadia Hospital as well, is to bring down the dosage and increase the gap. this brings down the cost. So emicizumab is your answer to perhaps inhibitors, to perhaps, a lot of all that was discussed today. Also, I realized that there are a lot of trainees as well as practicing pediatricians. I would like to quickly mention some of the cases that I have seen and what is it that you all should watch out in your practice. Because if all of us do not have, when the patient walks in, we don't have all the diagnosis and the laboratories at our beck and call. So just a couple of things. If there is a knee swelling, okay, and the child is in pain, and you feel that it is a fluid, please don't aspirate. Because if you aspirate, you're releasing the tamponade effect, you're drawing out blood, and it actually worsens, the joint. So if there is a hemarthrosis, the first thing to do is not to aspirate. I've had, so if it's a severe hemophilia, it's very easy to diagnose. But what if it's a mild hemophilia and a moderate hemophilia? So I had a patient who came in with a hemoglobin of 6 and bleeding from the site of dental extraction. He had excessive bleeding, delayed bleeding. He went back to the dentist. The dentist actually sutured it. So this increased the bleeding and the child was in trouble and he was just oozing out from that site. I had a child with a splenic rupture and he went to school, injured himself while playing on the bench. And they came from Hyderabad actually. And my colleague who's a pediatric surgeon, he said that they're saying that there is some collection. Should I aspirate? I said, no, wait, do a PT-PTTK. And if your PTTK is even slightly prolonged, friends, don't dismiss it. Please work it up. And this child was also a mild hemophilia. I've had a grandfather who came with a grandchild. And the grandfather said, I've had numerous, like swelling in the joint. He was diagnosed at the age of 72 for a CABG at Lilavati. And after that, when the grandchild was born, his daughter's child, immediately he said that, no, this child is likely to have hemophilia. And that's how they came. So at your end, please do not miss say that, okay, this is a mildly increased PTTK. Go to family history. Make sure that you take the mother's family history. If you have a history, fine. Please remember this is an X-linked recessive disease and you're going to have a 30% chance of a new disease which is developing in the child or in the family. So this is very important. There was one more thing. Yeah, blood collection. When you know that the child is a likely bleeder, please be very careful with blood collection as well, because we've seen entire arm full of blood and that causes a compression syndrome. So after doing a blood collection, please ensure that the mother holds the site of blood collection and does not keep, picking up her thumb to check whether there is a bleed. I've also seen a tonsillectomy and the child died actually. So be very, very careful of a mildly prolonged PTT. Severe hemophilia, no problem. But the mild and the moderate hemophilia is something that you as well as your pediatric surgeons need to watch out for.
I think the good news is that of all the studies, research going on gene therapy, hemophilia has the best result from CMC Vellore.
That is
I
true.
think it's very promising.
It is
Of
promising.
sickle, thalassemia, and hemophilia is the best.
Yes, ma'am. Yeah. But everything is going to take.
I know, yeah.
But anyway, emicizumab is what we are using. And for factor 9, we are using the long-acting factor 9, which is very, very prohibitively expensive. But I have used it at Lilavati recently in a factor 9 child, deficient child, and he's doing very well.
Is it given every month?
So it's given between 7 to 10 days because that's the half-life.
Okay.
But it is frightfully expensive. It's like 2.6 lakhs. But it was a company patient, so they were able to afford it, ma'am.
Thank you.
Thank you, ma'am, for your experts' comments. Now, the next speaker is Dr. Anna Sahib Lokhande. He will be talking regarding the iron deficiency anemia, customizing optimal therapy. Now, I request Anna Sahib, sir, please start your presentation.
Am I audible?
Yes.
Good evening, all the respected teachers, speakers,
Anna sir, start from the first slide. This is your last slide. First slide and full screen. Make it full screen.
yes. Good evening, respected
No,
dignitaries.
still. Yeah. Please go ahead. Go ahead.
Good evening, respected dignitaries and the delegates and the experts for today's Friday Punch. Today's my topic is iron deficiency anemia, customizing optimal therapy. So anemia is a condition in which number of red blood cells and their oxygen carrying capacity is insufficient to meet the body's physiological demand. As WHO has given cutoff values, as we can see, in young children's most common disorder prevalent is 6 to 59 months. Near about 55 to 60% of the children, they are affected with the nutritional anemia. So severe anemia is less than 7, and so on. As we know the all these values. So how it affects the children? So children are affected in many ways. They have poor developmental outcome, poor cognition, concentration, memory, and schooling is affected. They have also depressed immunity. They get repeated infections, poor motor developments, increased fatigue and shortness of breath, low endurance, pica, breath holding cells, and many more symptoms we encounter during our examination. So iron deficiency anemia lab tests, as we already know that all these lab tests are important, but what is important is clinical examination where you can compare and see the paleness of the body, and this is the definitive sign where we can investigate according to the RBC count, hematocrit value, red cell indices, RDW, iron content, ferritin level, transferritin saturation, and all the things they are giving the clues to the iron deficiency anemia. So how we can manage this iron deficiency anemia? So we can give dietary supportive therapy. We can provide oral iron therapy. We can provide parenteral iron therapy, and counseling of the parents is very important. So these are the values where the iron requirement in various age groups. As birth to 6 months, 0.27 milligram per kg is required for male and female. 7 to 12 months, 11 milligram per kg. 1 to 9, 10 milligram per kg. Adolescent, 18 to 11 milligram. So most of the patients, they are found in the 6 months to 59 months of the age group, where the nutritional demands are increased, iron demands are increased. So from where we are getting this iron? So iron is derived from the heme iron and non-heme iron. So derived from the hemoglobin found in the blood sources, meats, red meats, seafoods, and liver. These are the non-vegetarian sources through which we get the heme iron, and the non-heme iron which we get from the plant sources and fortified foods. That is the legumes, nuts, seeds, leafy green vegetables, dried foods, fortified foods, eggs. So there are fruits, top fruits, which are also giving the iron to our body. So these are the gooseberries, raspberries, lime, and raisins. These are the important. So the apple contains only 0.1 to 0.2 milligram iron per 100 grams. Dried apricots is very rich source of iron. Mulberries, prunes, raisins, they are dates. They are very good source of iron. So whenever we take this iron, there are some factors which are facilitating and some factors which are inhibiting the iron absorption. So dietary factors, heme iron is absorbed better than the non-heme iron. Factors that enhance the non-heme iron, they are the ascorbic acid, that is vitamin C. If they are taken along with meat, poultry, fish, they are better absorbed. Low pH, histidine, cysteine, lysine, these are the enhancing factors. Factors which inhibit non-heme iron absorption, these are the calcium, phytates, tannins, which are present in the tea and coffee, especially in the after the food. So here we can see that these are the pictorial presentation where they increases the absorption of iron, and these are the milk, tannin, coffee, these are decreases the iron. Also, we need to tell the parents that after giving the milk, we should not give the iron at least for 2 hours. And after meal also, we should avoid to give them iron for at least 2 hours. And usually the iron is given in the evening doses or night doses, so that it will be better absorbed. So there are few dietary, I want to explain some dietary sources. Drumsticks, which is easily available, cheaper. Everybody can take this. It is available in the village, city, metro cities. So it gives 0.36 milligram of iron per 1000 gram. So in this picture, I want to show that only drumstick curry is not available. So if somebody doesn't like drumstick curry, they can make a drumstick soup. They can make various formulations and preparations so that your child will like these preparations, and they will be definitely helpful in treating the iron deficiency anemia. Second example is jaggery, which is having 11 milligram of iron per 1000 gram. This pictorial presentation shows 6 type jaggery seeds. So we need to give the different recipes of the same food item to offer the variety of flavors, textures, and cooking techniques catering to the individual preferences and dietary needs. So another example here is the spinach. So most of the children, they don't like spinach. Even adults, they don't like spinach sometimes. So there are 35 recipes. If we go to the YouTube, there are so many recipes. We can make parathas, puris, we can make paneer, we can have also our favorable idli. So many things are available on internet. So we can ask the parents to prepare these various textures and flavors so that the children will definitely take interest and accept this type of iron-rich food. So in iron deficiency anemia, now how to manage? After dietary therapy, sometimes we have to proceed with the oral iron preparations. So there are various oral iron formulations present. So basic salts are ferrous against ferric. All iron salts have reduced from the ferrous form to enter the mucosa, and bioavailability of the ferric preparation is 3 to 4 times less than that of the conventional ferrous preparation. So the ferrous form is preferred among the all this, and these are also cheapest preparation available. So most commonly available in the government setup is ferrous sulfate, and also most commonly accepted. It gives 20% elemental iron, and mainly it is used in the tablet form. Syrup also exists. Another form is ferrous fumarate, 33% elemental iron, similar efficacy and gastrointestinal tolerance to the ferrous sulfate, more stable, tasteless. So which is the best iron preparation? Ferrous sulfate continues to be a gold standard and the preparation of choice. Syrup ferrous sulfate has a limitation of bioavailability and the shelf life. So here we can see the ferrous sulfate gives 20% elemental iron, and ferrous fumarate is giving 33%. So ferrous gluconate, fumarate, ascorbate, these are the acceptable preparations in the private practice. There are other salts also, iron amino acid chelates, which are in India, mainly the ferrous glycine sulfate is available in the syrup form. No effect on color or taste of the food. Relative high bioavailability in the presence of dietary inhibitors. Here, when environmentally stable, chance of toxicity and overdose is less. So next is iron polymaltose complex. This is non-ionic iron polymaltose. Is a stable complex. Equivalent bioavailability as Fs. Absorption is better when taken with meals. No teeth stainings and slower improvement in hemoglobin. That is the only disadvantage. Oral iron therapy, route of iron therapy. The iron syrup is best given at the back of the mouth to avoid the discoloration of teeth and gums, followed by rinsing of the mouth with water. The duration of therapy, oral iron 3 mg per kg elemental iron per day results in the HB rise of 1 gram per deciliter within 4 weeks for children with mild anemia and within 2 weeks for those with severe anemia. Iron is administered for 2 additional months after hemoglobin is normalized. This is National Iron Initiative. So we give here from 6 months to 5 years. Frequency of administration of iron and folic acid twice a week on fixed days. Preparation is 1 ml of IFS syrup is 20 mg of elemental iron. Albendazole must be given for the deworming purpose. 5 to 10 years once a week. These tablets are given, and 10 to 19 years also once a week, according to the National Iron Initiative. So oral iron therapy, supportive therapy is also needed. Deworming is very important, and sometimes we need to administer cobalamin, folic acid, vitamin C along with the iron to enhance the absorption of the iron. Oral vitamin B12 is added where there is a poor response to the oral iron alone, or in children with combined vitamin B12 and iron deficiency, that is dimorphic anemia. How we assess the response to the iron deficiency anemia? After starting the treatment, the response is expected, and within 24 hours, that is decreased irritability, lethargy, and there should be sense of well-being. Appetite generally improves within the 24 hours. Peak reticulocyte count is seen within the 5 to 10 days. Hemoglobin rises by average 0.25 to 4 gram per deciliter per day. Hematocrit rises by 1% per day during the first 7 to 10 days. Thereafter, slower rise of 0.1 to 0.15 gram per deciliter per day is seen in rise in hemoglobin. The timing of scheduled follow-up visit should be for severity, according to the severity anemia, day 7 and day 14 for clinical evaluation and complete blood count, that is CBC. After giving the therapy, if there is a failure for the iron response, then when it occurs, failure to attain the adequate response to the therapy, we can conclude after 2 to 3 weeks is designed as a failure to respond. If there, we have to check the poor compliance, inadequate doses are the most important causes of failure to respond to the iron supplement. The main cause of inadequate response are oral therapy, is incorrect diagnosis, complicating illness associated, poor compliance, insufficient dose, and continuing loss of iron and malabsorption. These are the few causes which will lead to the poor response to the iron therapy. So once we get the poor response to the iron therapy, we need to think about the parental preparation. So what are the indications for the parental iron therapy? Poor adherence, intolerability due to gastrointestinal side effects, need for rapid replenishment as of hemoglobin and iron stores rather than the overcause of several months, that is preoperative situations, ongoing blood loss, as in case heavy uterine bleeding, mucosal telangiectasis, iron malabsorptions, coexisting inflammatory diseases, chronic kidney disease, and some genetic forms of which are refractory to oral iron, that is IDF. So what are the choices available with the parental iron therapy? The earlier agents were iron dextran, iron sucrose, and the ferric gluconate are associated with significant adverse reactions. The newer third generation formulations like fluroximol and ferric carboxylatase are iron carboxylate complexes that slow release of iron, resulting in more favorable and safety outcomes. So these are the ferric carboxymaltose, which is commonly used in today's practice, though others are having more side effects than the ferric carboxymaltose. So how to decide the dosage? The total cumulative dose of parental iron is required can be calculated by using Ganzoni's formula, that is total iron dose is equal to actual body weight into 15 actual hemoglobin into 2.4 plus iron stores. And iron stores can be calculated as 500 milligram for children above 35 kg, and if child's weight is less than 35 kg, it should be calculated as 450 milligram by this formula. There are some side effects of parental iron therapy. Serious hypersensitivity reactions occur, life-threatening conditions, and fatal anaphylactic reactions can occur. Other mild adverse reactions reported: iron sucrose are hypertension, nausea, vomiting, diarrhea, constipation, abdominal pain, edema, fatigue. These are the milder adverse effects. Risk of hypersensitivity, it is present in some patients where there are allergies, immune or inflammatory conditions, or those with the history of severe asthma, eczema, and other atopic allergy. So after giving the iron therapy, if the patient is not responding, then we need to consider some rare conditions like iron refractory iron deficiency anemia. A new cause of hereditary anemia has recently reported and described as a iron refractory iron deficiency anemia. The biological hallmarks of the disease are microcytic hypochromic anemia, low transferrin saturation, and normal or high serum hepcidin levels. refractoriness to oral iron, and slow and partial response to intravenous iron injections are the features of the disease. The prevalence of the disease is still unknown. So, in any case, we preferably first we need to give the oral iron, and then we can think of giving the parenteral iron. So, how we can prevent the iron deficiency anemia? So, in the beginning only, when the mother is ANC, we need to give the iron supplement so that mother's iron store and the hemoglobin will be on the higher side. We can have a procedure like delayed umbilical cord cutting for 1 minute so that it will also help in the early infancy to rise the hemoglobin. Breastfeeding, iron fortified formulas, they are available. Properly starting the complementary feeding, then iron supplements, iron rich foods, complementary foods, avoid cow's milk as it can cause cow's milk allergy and also associated with anemia. So what pediatricians and IAP is doing for this anemia for our country, last 24 CIP action plan, they have started with Anemia Mukta Bharat. Indian Academy of Pediatrics supports the policy of Government of India for Anemia Mukta Bharat 2024. IAP is committed to take program forward through the 3570 branches and more than 45,000 members all over the country for the children and adolescents to receive iron and deworming as per the schedule prescribed by the Government of India. Also, they have done the press releases, given the information, education, in communication in the schools for the anemia. They have also given the school health checkup for anemia, checking the hemoglobin, and whenever there is a need, they have prescribed the iron also. This year, our Dynamic President CIP, Dr. Vasant Khalatkar, he has started the yatra like a bye-bye anemia throughout our country with overwhelming response and enthusiastic participation to combat the anemia and the spread awareness. Our president has started this bus yatra for bye-bye anemia and breathe easy yatra. So together we are making the difference for one city, one life at a time. So these are the few pictures where our presidents, our Yavatmal Pediatric Association is also working. They are doing the bye-bye anemia bus and they are making awareness. Here the president, sir, they are also making the awareness. We are pink bus. We can see this is pink bus and bye-bye anemia concept has been explained to the society. So this is from my side, and I'm also want to say bye-bye anemia. Thank you for giving me opportunity, MAHAIP President sir and team. Thank you so much.
Thank you, Anna Sahib sir. Dipti ma'am, your expert comments.
Thank you, Dr. Lokhande. You have covered it very well, all the aspects. I would like to stress that in real life, what is the closest differential diagnosis of microcytic hypochromic anemia is thalassemia trait. So I think there are ways by which we can differentiate. Dr. Lokhande, can you talk about it? Differentiating thalassemia trait from iron deficiency anemia?
Thalassemia trait, madam, history is important, consecutivity is important.
Yes, apart from history, there are some indexes which we look for. RBC count.
RBC count in peripheral smear, Menzer's index.
Yes. And the other thing is, now the health surveys have found that what is anemia is not due to only iron deficiency. Usually they are combined. You did mention about B12 and vitamin C, folic acid, sorry. So it is very important that these anemias are combined. So you have to look for other deficiencies also. Dr. Swati, would you like to add something?
Swati, madam.
Just a fun fact. We always talk about pica. So I just want to just share that pica is actually named after a bird, magpie, which look, kind of closest cousin to our crow. And as we all know that crows would eat everything, they are omnivores. They eat food, whatever that excites them. So that is how the term pica has come about. It's from the Eurasian magpie called pica pica. So just a fun fact like that, nothing more. I think Dr. Lokhande, you did an excellent presentation, and we all kind of revised iron deficiency anemia.
Yes. Thank you so much, ma'am. Thank you.
Thank you, Dipti ma'am, and thank you, Swati ma'am. Over to you, Ravindra sir, for
Yes.
next speaker.
Yes. Thank you, Sachin. Very good presentation by the Chandak madam and Anna Sahib Lokhande. So I invite Dr. Prasad Dham.
Dr.
So,
Ravi,
yes.
Dr. Prathi has a question.
Okay.
She has raised her hand. Dr. Prathi.
Dr. Prachi.
In the chat box, there is a.
Just, we'll check, madam. Just,
At the last, we will take a question, sir.
Hello.
Hello. Yes.
Good evening, sir. Sir, actually, my question is, ma'am said we have combination of anemia most of the time, folic acid, B12, and iron deficiency. So iron, always we should supply all the three. Just the query is, on one side we say combination drugs are not allowed nowadays. Most of the combinations are banned. So should we give all the three drugs in different ways at different times, or one by one, finishing one dose by one, like for it is B12? How should we go?
Dr.
Ma'am,
Prachi,
sir.
I did not mean always give combination. I said whenever there is anemia, rule out B12, folic acid, deficiency also along with
Yes, ma'am.
iron. We do not always have to give combination therapy.
And whenever it is in combination, in that case?
We have to give B12 along with iron. We don't give one after the other.
Okay, so should we use combination drugs or should we give it one by one?
I give them separately. I don't give combination.
Okay, ma'am. Thank you, ma'am.
Swati, madam.
So, ma'am, I generally use tonoferon, which has a little bit of everything, and then we give full white as well. Or otherwise, if it's an older child, then give Polinext, which has both folic acid as well as B12. So generally, the folic acid B12 goes together, and the ferrous sulfate goes. But very difficult to find just single iron, means I don't know of a preparation which is only iron without anything else. Of course, I don't go for the fancy preparations, but I think most iron syrups have something or the other with it.
Okay, so Prachi
Thank you, ma'am.
must be satisfied with the
Yes, sir.
expert's answer.
Yeah, thank you, sir. Thank you, ma'am.
So now I welcome Dr. Prasad Dham, sir, for his presentation on the sickle cell anemia. What is the new? I welcome Dr. Prasad.
Hello, friends. Good evening. I'm Dr. Prasad Dharm. I'm practicing general pediatrician. That is my disclaimer to start with, because at the Dharashiv place, we are not seeing too much of sickle cell anemia. And still, I have been allotted this topic. So I have tried my best. And in front of the stalwarts in the pediatric hematology, such as Swati ma'am and Dipti madam, and I will thank the MAHAIAP, all the dignitaries of the MAHAIAP, and my past presidents, past president of the Dharashiv IAP, Pofre madam, for giving me chance to present this topic. So I will stick to the time. So the topic is sickle cell disease, what is new? So we will start. Although the topic mentions what is new, not all the slides are going to be all the new topics. Some slides, most of the slides are the basic only. Some of the slides are having the content of the new additions in the treatment of the sickle cell anemia. So basically, it is the most common hemoglobinopathy in the pediatric population. It is actually the qualitative mutation in the beta globin chain gene, and where the hydrophilic glutamic acid is replaced by the neutral valine at the 6th position. So that results in the formation of the sickle hemoglobin, and that is something that will bring all the clinical manifestations when it is exposed to the hypoxia. This disease has considerable phenotypic diversity. So you should have a high index of suspicion so as to find the patients in the general population. So first we will see the normal adult hemoglobin A that contains the 2 alpha and the 2 beta chain that usually do not interact. These hemoglobin molecules do not interact with each other. On the contrary, the sickle hemoglobin, when it is in a deoxygenated state, it interacts with each other and it undergoes the polymerization and it forms the rigid polymers that give rise to the sickle-shaped RBCs. And that is one of the conspicuous findings, is that fetal hemoglobin, when it is a non-polymerizing type, and hence usually the young infants, they are relatively they usually do not show the clinical manifestation of the sickle crisis usually in the first year of life. So this slide mentions the basic pathophysiology of the sickle cell disease. That is, when the patient is having a sickle hemoglobin, when it is exposed to the hypoxia, sepsis, and dehydration, that sickle hemoglobin undergoes the polymerization, and that results in the formation.
Dr. Prasad,
yes,
your
sir.
slide is not visible.
Oh, yeah.
Just recheck.
Oh.
Sachin.
Sir, it is visible now?
No. Pallavi, Sachin, if you have any slides, you can run.
Actually, I am trying. Hello. मी ट्राय करतोय सर. लेआउट मध्ये गेलेलो आहे. मी ऍक्च्युली डाउनलोड केलेलं आहे, पण लेआउट मध्ये गेल्यावर डाउनलोड वर जाऊन.
प्रसाद सर, तुम्ही एकदा हे करून पहा ना तुमच्या ज्यामध्ये सिस्टम मध्ये. सध्या कोणाचं स्क्रीन विजिबल होतंय?
डॉक्युमेंट्स.
प्रसाद सर, तुम्ही पुन्हा एकदा शेअर करा, होऊन जाईल ते.
झालंय सुरू झालंय.
झाले का सर?
झालं आता. हा.
Okay, thank you.
Yes.
So when the sickle hemoglobin is exposed to the hypoxia, sepsis, and dehydration, the sickle hemoglobin undergoes the polymerization that results in the formation of rigid, sticky, and sickled RBCs, and that is the main thing behind all the clinical manifestation of the sickle cell anemia. It leads to the microvascular occlusion and hemolysis. So these are the
Yes, it is visible.
So these are the common clinical features. That's how usually the patients of the sickle cell disease, they are present to us. That is, the first one is the acute chest syndrome. That is the most common cause of admission, also most common cause of death in sickle cell anemia. And you should always have a high index of suspicion to find out the acute chest syndrome, and you should always monitor the sickle cell patient for the development of the acute chest syndrome. Past history of the acute chest syndrome, asthma, surgery, and infections, they are the high risk factor for the acute chest syndrome development. And you should look for the breathlessness, cough, fever that may be present or may not be present. And the management point of view, we should stick to the basic, always give the ABC and monitor the oxygen saturation to keep the oxygen saturation above 95%. Look for the new pulmonary infiltrates on the chest X-ray, and every sickle patient, whenever it is comes in the emergency room, it is always better to hospitalize him at least for the 24 to 48 hours for the observation. And any sickle patient, when comes with a fever, then it is better to give empirical is to start the IV antibiotics, give supplemental oxygen, and early simple blood transfusion for the hypoxic patient is the key to management. Next common clinical feature that is in the sickle cell anemia is the sequestration crisis. It can be both splenic or hepatic. It is a significant cause of the acute anemia in the sickle cell anemia. It can occur as early as 5 weeks, but most common age is 6 months to 2 years. And usually in the homozygous sickle, that is sickle cell anemia, autosplenectomy usually occurs by 5 to 6 years. Hence, the sequestration crisis usually after 6 years are uncommon. But in the heterozygous state, there is usually no autosplenectomy. Hence, they can develop the sequestration crisis even in the adolescence and the adulthood. And for the sequestration crisis, always look for the left or right hypochondriac pain, sudden fall in the hemoglobin, rapid splenomegaly, hypovolemia, and hepatomegaly. And hemodynamic stability is the cornerstone of the management, and careful blood transfusion usually at 5 ml per kg of PCV, so that the post-BT hemoglobin is usually kept around 8. We should avoid the transfuse the more PCV that we normally transfuse in the normal babies because as the sequestration crisis resolve, the sequestered trapped blood re-enters the circulation, and that can give rise to hyperviscosity. The next is the stroke. This is the most devastating complication, and as well as it can be a presenting feature in 10% of the sickle cell anemia patients. And it is usually that 10%, there are two types of the stroke, that is overt stroke and the silent infarcts. So overt stroke is usually seen in the 10% of the all sickle cell anemia patient, but the silent cerebral infarcts, they are usually seen up to the tune of 35%. So usually in the absence of, if we do not screen for all the sickle cell anemia patient by the primary prevention, such as the transcranial Doppler studies, so 10% of all the patient will suffer from the overt stroke, and 35% will have a silent cerebral infarct. So always look for the seizures, headache, Press syndrome, that is posterior reversible encephalopathy syndrome, venous seizures and headache. And the key for the management of the stroke is always the oxygen administration to keep the saturation about 96% and transfusion urgently whenever, whatever may be the type of transfusion, simple or it can be a exchange transfusion. The aim is to keep the sickle hemoglobin less than 30%. So transcranial Doppler screening has actually revolutionized the management of the sickle cell anemia and its most devastating complication, stroke. And whenever almost all the babies who are above the 2 years of the age, we should start the screening for the transcranial Doppler study in the terminal internal carotid and the proximal middle cerebral artery. And when the patient, the time averaged mean of the maximum blood flow velocity is more than 200, then it is a risk for developing a overstroke. And also we should, as early as possible, we should start the regular blood transfusion therapy and put the patient on hydroxyurea. So this strategy has resulted in over 90% of the reduction in the stroke. Next, this aplastic crisis, most of the time it is a temporary red cell aplasia, and you should, any patient of the sickle, when presents with fever and rapidly developing pallor, you should always have a high index. It is usually always suspect the pyrovirus B19 infection, and the key for the management is again, a simple blood transfusion at as early as possible. The most, apart from the vaso-occlusive crisis, the infection and the bacteremia is the main presenting feature of the sickle cell disease in all over the world. As early as at the age of 6 months, the sickle cell anemia infant, they develop the abnormal immune function, and they are especially prone to sepsis due to the capsulated bacteria. And by 5 years, they all have the functional asplenia. And any patient of the sickle cell anemia who is diagnosed, and if he presents with fever, we should always admit the patient at least for 48 hours, and after sending all the sepsis screen, and start the patient on IV antibiotics. And if we found salmonella or staphylococcal infection, we should search for osteomyelitis. Priapism is again the common manifestation, which can be seen in almost 20 to 30% of the babies, and mean age of the presentation is 15 years, but it can occur as early as around 2 to 3 years of the age. And there are two types. One is stuttering, and another is one is the stuttering, and another one is a prolonged priapism. And usually the priapism in the sickle cell anemia indicate the low flow state, and it is due to the venous stasis built in the corpora cavernosa. Hot shower, temporary pain relief with analgesics, and consultation with the urologist, we can manage the patient of the priapism. Some people say that when we give blood transfusion to the patient of the sickle cell anemia, there are more chances of the neurological complications, but most of the people are now disagree with this finding.
Prasad sir, please restrict to 8 minutes. Please.
Yes. The next common acute complication of the intrahepatic cholestasis, hyphema, the central retinal artery occlusion, orbital infarction, and the orbital compression. So these are usually the acute presentation of the sickle cell anemia. And the patients who are on the blood transfusion therapy for long time, they can develop the iron overload, then also avascular necrosis of the long bones, leg ulcers, pulmonary arterial hypertension, and the renal complications like hyposthenuria, nephrotic syndrome, interstitial nephritis, and also sickle cell retinopathy. So from the treatment point of view, though the many newcomers are there in the management of the sickle cell anemia, these two modalities of the treatment still holds true in our country: regular blood transfusion and hydroxyurea. Regular blood transfusion is the cornerstone of the treatment till 1998, and it is used both for the treatment of the acute complication and for the chronic treatment of the prevention of stroke. Simple blood transfusion and exchange transfusion, you can buy the manually or automated erythrocytophoresis to decrease the iron load. And one thing that is, we should know that you should always perform the extended cross-matching for the patients with sickle cell anemia, as they are prone for developing the alloantibodies. Carefully select the amount of PCV to be transfused so as to avoid the hyperviscosity. Next drug that is really a game changer that was introduced in 1998 is hydroxyurea. It is actually an antineoplastic drug that acts by increasing the fetal hemoglobin concentration, and also it increases the RBCs that containing the fetal hemoglobin. It also alters the expression of the adhesion molecules so that it is said that it prevents the vaso-occlusive crisis. It should be started to all the sickle cell babies from the 9 months of the age. And the starting dose is 15 to 20 mg per kg once a day, and that we should increase by 5 mg per kg per dose every 8 weekly for the maximum of 35 mg per kg. And the therapeutic effect of the hydroxyurea usually take the several months, so that it is the counseling of the parents is of utmost importance. And we should always monitor the absolute neutrophil count and the platelet count and try to keep it ANC about 2,000 and platelet count above 80,000 to 1 lakh per microliter. So these are the newer treatments. That is the L-glutamine. It is basically the essential amino acid that is required for the synthesis of the natural antioxidants such as NAD, nitric acid, and reduced glutathione. It is available in the powder form. It mainly acts by reducing the oxidative damage of the RBCs and maintain the muscular tone. It is usually used in the children more than 5 years. It was first approved in 2017 and dose is 5 gram of powder twice a day in babies less than 30 kilo and more than 30 kilo. It is 10 gram powder twice a day. This drug voxelotor is first approved in 2019 with the brand name of Oxbrita by the Pfizer, I think. The sickle hemoglobin polymerization inhibitor that works by increasing the oxygen affinity of the hemoglobin. It is administered once a daily oral tablet form in children for more than 12 years of age. And in 2021, FDA approved for its use in 4 to 11 years age group also. But recently in the September 2024, Pfizer company that is making it voluntarily withdraws all the lots of the Oxbrita and discontinued active clinical trials of the voxelotor, as overall benefits of the Oxbrita, they are no longer outweighs the benefits. So the next molecule is monoclonal antibody to the P-selectin, that is crizanlizumab. It binds to the P-selectin on the platelets and the endothelium, and it blocks the interaction with the P-selectin glycoprotein ligand 1, and thus it prevents the vaso-occlusive crisis. It is approved for the use from the 15 years of age to 65 by FDA. Dose is 2.5 mg per kg. Dose is from 2.5 to 7.5 mg per kg as IV infusion 4 weekly. But again, this as the same as the case of voxelotor in January 2023, the Novartis company that was making this, that is the manufacturer of this monoclonal antibody, it again withdraws all the lots of the crizanlizumab as they failed to, they found no statistical significantly difference in the annualized rate of the vaso-occlusive crisis in the patient receiving this monoclonal antibody and the placebo.
Sir, we are lagging behind the time.
So this is my last slide, sir.
Okay.
This is the newer treatment that was introduced in 2023 by FDA, that is gene therapy. There are two types, Casgevy and Lyfgenia. The Casgevy, it is actually basically based on the technology CRISPR-Cas9 that is clustered regularly interspaced the short palindromic sequence that is basically a defense mechanism of the bacterium, prokaryotic organism with combination of the CRISPR associated protein 9 basically, and this they use to modify the hematopoietic stem cells. They use the guide RNA which direct the Cas9 protein to target the specific DNA sequences, and these Cas9 enzymes, they act as a molecular seizure to cut the DNA at the specific location, and then that is repaired. Basically, it targets and suppresses the BCL11A gene that normally is a suppressor of the fetal hemoglobin expression. Hence, it ultimately results in the increased fetal hemoglobin production, which does not sickle. It is approved for children more than 12 years of age. Second one is a Lyfgenia. It is a gene addition technology that uses a lentiviral vector. That lentiviral vector carrying a modified beta globin gene is added to the patient's stem cell, and which results in the formation of modified hemoglobin A, T87Q. That is the beta cell at 87 position, that is single base pair exchange with that is threonine is with glutamine. That this modified hemoglobin A that is has a lower risk of sickling. So prior to the treatment of the gene therapy, the patient has to undergo the myeloablative conditioning, and then these modified stem cells are infused in the patient's of sickle cell anemia. And then the last, that is a cure that is said, that is hematopoietic stem cell transplantation from the HLA matched sibling without having a sickle cell disease, but that is still far from the reach of the Indian population. So this, still in our setting, the treatment of the sickle cell anemia still remains to the hydroxyurea and blood transfusion regular, with anticipatory guidance to all the sickle cell patients that prophylactic penicillin till 5 years of age, routine vaccination with special emphasis on capsulated bacteria and Salmonella typhi vaccination, annual influenza vaccination, as they are prone for the interstitial lung disease, spleen palpation education of all parents, and transcranial Doppler screening importance, and it should be started by 2 years of the age. Thank you.
Thank you, Dr. Prasad. The Dr. Dipti Jain, madam, please comment on these new perspectives, gene therapy or drugs or stem cell transplant. What is your experience?
Yes. Thank you, Dr. Ravi. First of all, I want to tell you that the sickle cell disease in India is different. The haplotype is different from what we read in the books about Africa, US, and other countries. So there are many differences between sickle cell disease phenotypically, genetically in India and other places. So the gene therapy also will be adapted to Indian haplotype. So we cannot use what is already there, FDA approved in US and UK. So what our scientists, they are in advanced stage, but they are at a level that we are, because we have very high hemoglobin F level. And one of the way gene therapy also acts is increasing the hemoglobin F level. So it is that we have to have our own experience about sickle cell disease, and we cannot generalize whatever we have in the literature. The other thing I wanted to talk about is L-glutamine, not available. For us in India, it is mainly supportive care and hydroxyurea.
Yes.
And glutamine available in our country is Ceted, which we give as amino acids supplement to malnutrition. The actual molecule of L-glutamine is not available in India. It is very high dose for anti-sickling activity. Crizanlizumab and voxelotor, as you said, were thought to be promising, but are no more used. So today, the option is, the best option which we have in our country is hematopoietic stem cell transplant, but it is not for everyone. If I have 100 SS, I would say only 2 qualify for this transplant, because hydroxyurea is a wonderful drug and that decreases the symptom. So I think in view of the shortage of time, I just want to say that Indian sicklers are different. Anemia, infection, and pain are the main presenting symptom. Acute chest syndrome and stroke, yes, but priapism is not common in Indian population. It is less than what is reported in other places. Only thing I would like to stress here is one has to screen as the patients are living longer. We are seeing organ damage in second and third decade. So we need to screen for this organ damage right from childhood. As he said, TCD is very important. From 2 years to 18 years, all children must undergo transcranial Doppler annually. The other important, where we can do something, we can put them on blood transfusion, increase the dose of hydroxyurea to prevent an attack of stroke. The second is we must do microalbumin every year in all children about 5 years, because in our country, renal failure is very common by second and third decade. So I think these, apart from ophthalm and other eco, many more things, for me, I think most important is to prevent stroke and to prevent renal failure. That's it. I will stop here.
Thank you, madam. Now I request Dr. Amol Karangre to talk on thalassemia, iron chelators. Please be specific. I humbly request because we are already late. So please stick to iron chelators only. So I welcome Dr. Amol Karangre. Thank you, Jain Madam, for your expert comments. Hello, Dr.
Amol sir, kindly unmute yourself.
Amol,
Amol.
unmute. Amol,
आवाज म्यूट है अमोल.
Amol sir, kindly unmute yourself. Yes, thank you.
Am I audible?
Yes,
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 sir. Yes, sir.
yes.
Can I continue?
Yes.
Thank you for giving me opportunity to speak over this prestigious platform of MAHAIP. Can you share my slides, please?
Ravindra sir, you have to share the slides.
ट्राय करतो बरं का मी. मला जमेल का नाही.
Pallavi madam, is it possible for you?
No, sir, not yet.
पल्लवी मॅडम तुम्हाला जमेल.
नाही सर, माझ्याकडे आज ब्लॅकआउट मुळे कशातच बॅटरी
नाही,
नाहीये.
पण मला सांगा, मी शेअर करतो, पण माझ्या
हो, sir.
याच्यात कुठे जाऊ मी शेअर
तुम्ही
केल्यानंतर
आधी
डाउनलोड.
प्रेझेंटेशन ओपन करा सर. प्रेझेंटेशन
हा,
ओपन करून ठेवा.
प्रेझेंटेशन ओपन करतो मी. हा,
हो, झालं. आता
एक
शेअर स्क्रीन या
मिनिट केला.
बटनवर क्लिक
हा, प्रेझेंटेशन
हा.
ओपन केलं मी.
हा, ते मिनिमाइज करा आणि झूम वर जा.
येस, झूम वर गेलो.
झूम वर शेअरच्या बटनवर क्लिक करा, ग्रीन बटन.
एकच मिनिट, शेअरच्या बटनवर क्लिक करतो. राईट. हा,
त्याच्यामध्ये विंडोज दिसतील छोट्या वेगवेगळ्या
त्याच्यामध्ये
तुम्हाला.
मला एकच मिनिट. हा, स्क्रीनवर नाही. एकच मिनिट मॅडम, एकच. जस्ट 1 मिनिट.
येस सर.
माझे ना बरेच ओपन आहे, बरेच पीपीटी बंद करतो मी. हा हा, आता एकच शेअर मध्ये. हा,
शेअर स्क्रीन मध्ये तुम्हाला प्रेझेंटेशन दिसेल जे आता शेअर करायचे.
हो ना
Just click
मॅडम,
on
ते
that. हा.
नाही. डॉक्टर दीप्ती सीवी दिसते. एकच मिनिट मॅडम. हा
हो सर.
हा, दिसतंय आता मॅडम.
नाही सर, अजून तरी नाही दिसत आहे.
शेअर.
त्याच्यावर डबल क्लिक करा. त्याच्यावर डबल क्लिक करा सर. त्या हा,
अच्छा,
येस.
आता आलं ना.
हो, आलं सर. आता त्याच्यावर फक्त तुम्ही आता फुल स्क्रीन करा.
येस,
राईट बॉटमला जाऊन.
करतो.
Yes, sir. It is full screen now. Amol sir, you can start. Thank you.
Yes. My topic is myself, Dr. Amol Karangre, consultant pediatrician at Katol, Nagpur. So my topic is thalassemia blood transfusion. Everyone knows thalassemia is a blood disorder. There are various clinical types, but most relevant types are alpha and beta. According to the chain whose synthesis is impaired. There is also one more type, transfusion dependent thalassemia, transfusion non-transfusion dependent thalassemia, based on the clinical severity and transfusion requirement. Sir, I am not able to see slides.
आता it is moving. Just एकच मिनिट. आता दिसतंय अमोल.
नाही सर, नाही.
हा,
सर, तो पीपीटी दिसतीये. But
पीपीटी दिसते.
go
Previous
to the
slide,
second
previous
slide.
slide.
Sir, want second slide.
Second slide, sir.
एकच मिनिट. ही फर्स्ट झाली, ही सेकंड. ठीक आहे.
सर, याच्या आधीची स्लाइड आहे सर.
ही का?
याच्या आधीची स्लाइड.
ही.
ठीक आहे सर, ठीक आहे चालेल. Thalassemia, everyone, thalassemia refers to group of blood disorders characterized by decrease or absent synthesis of one or more of the normal globulin chain. There are various clinical types, but most clinical types are alpha and beta. And there is also one more depending on the clinical severity and transfusion requirement, that is transfusion dependent and non-transfusion dependent thalassemia. Sir, slide share नाही होत आहे सर.
स्लाइड शो करू का? का रीडिंग व्यू टू रीडिंग व्यू?
फर्स्ट स्लाइड, सेकंड स्लाइड सर, सेकंड.
हो ना, मी केलेलं आहे, क्लिक केलेलं, मला दिसतंय आता.
हा, आता येत आहे सर.
मध्ये गायब होते. पळते ऍक्च्युली. आता दिसतंय सर?
सर सेम प्रोटोकॉल ठेवा आता सारखा, फक्त स्लाइड नंबर सांगा. मोर स्लाइड नंबर.
हा,
ॲनिमेशन जास्त आहे.
हॅलो
हॅलो.
हा, दिसतंय का?
हा सर, पूर्ण येत नाहीये ती.
आता ते ऍक्च्युली स्लाइड्स ना मूव होत आहे ते.
Amol sir, I think you should try from your side. If you wish,
Okay,
I
ma'am.
can guide you, sir. We can try once.
Okay, sir. Okay, ma'am.
Ravindra sir, just stop sharing your screen.
Oh.
We'll try from Amol sir side. Amol sir, please open the PPT. If you are like opening from your mobile, make this screen in horizontal way.
इथेच थांबतो.
Dr. Amol, you don't have your PPT with you?
No, sir. Actually, I am not able to open here from my side.
Okay. In your laptop or your mobile?
I am actually my laptop stopped working at evening. Now I am
Okay, no problem.
from mobile.
Okay.
I will
No
just
problem,
read
no
this.
problem. Okay. Because we are getting very late. Our experts also have to take care of their time, no?
Okay, I will read just then.
Okay.
Okay, so second are blood transfusion and iron overload. Now, the mainstay of treatment in thalassemia is maintained blood transfusion, but it leads to iron overload. Say iron gets accumulated in various tissues. Occurs when iron intake is increased over a sustained period of time. In transfusion dependent thalassemia, and increased absorption of iron through GIT in non-transfusion dependent thalassemia. Now, this iron gets accumulated in various tissues like liver, bones, endocrine glands, is toxic to various tissues. Now, this repeated blood transfusion leads to iron accumulation, and the iron gets accumulated in various tissues, leading to complications. When it is accumulated in heart, leading to heart failure and arrhythmias in endocrine glands like heart, liver, and endocrine glands, pancreas, parathyroid gland, thyroid gland, leading to growth retardation due to growth hormone deficiency, delayed puberty, hypogonadism, diabetes mellitus, and hyperparathyroidism. In liver, complications like fibrosis or tumor may occur. Now, coming to topic, what is chelation therapy? Chelation therapy, repeated blood transfusion leading to iron accumulation in various tissues. So, to remove excess iron caused by regular blood transfusion, chelation therapy is done. And medicine used in chelation therapy, they are called as chelating agents or chelators. They bind labile iron, form complex, and excreted from the body. Now, before that, how will you monitor iron overload? So, first is by doing serum ferritin. Target values are 500 to 1000 micron per liter, and chelation usually started above level 1000. Second, liver iron concentration. So it is measured by MRI based methods. Normal values are up to 1.8 ml per gram of dry weight. and sustained high level above 15 ml per gram dry weight suggests a worse prognosis. Liver iron concentration can be used to calculate total body iron also. Third is cardiac iron accumulates later than liver iron and is rare before the age of 8 years. Now the aims of chelation therapy. So first is preventive therapy. Preventive therapy to maintain safe levels of body iron at all times. That is by balancing iron intake from blood transfusion with iron excretion by chelation. That is iron balance. And chelation is needed only to remove iron that is added with each transfusion. Second is rescue therapy. When clinical organs are in danger, so high dose chelation is needed to rapidly lower iron. Plus to remove iron added with each transfusion, plus provide continue therapy. Now, second is third aim is to improve survival. So effective chelation therapy significantly improves the survival and quality of life. It reduces morbidity and mortality also. Now, what are the objectives of iron chelation? So, to maintain body iron stores at safe levels at all times. Optimal liver iron 3 to 6 milligram per gram by MRI. Optimal ferritin 300 to 400 Ng per ml and 400 to 700 in younger children. No heart iron which is accessed by T2 MRI and no pancreatic iron. And to maintain body iron stores at the lowest level without incurring toxicity due to chelation therapy. Now, various chelating agents. There are three drugs are there: deferoxamine, deferriprone, and deferresirox. Now, first is deferoxamine. It is the first iron chelator in clinical use. So, route is subcutaneous or continue IV infusion. It removes liver and cardiac iron when given in adequate doses. So dose is 20 to 60 milligram per kg per day and 5 to 7 days per week. Then its half-life is very short, means approximately 20 minutes, and it binds iron very strongly. Yes, it has side effects. When side effects are there, when very high doses are used for years, means uh, high frequency hearing loss, tinnitus. When vision is impaired, then loss of visual acuity, field defects, impaired growth and skeletal development. Then other toxicities like local skin reaction, increased risk of infection, particularly because of Yersinia and Klebsiella. Now, what will we monitor during deferoxamine therapy? Serum ferritin, monitor if it falls below 1000 Ng per ml. Monitoring of eyes, monitoring kidney function test, and monitoring of growth. Contraindication, these are general contraindications like pregnancy and hypersensitivity, compliance issues present with deferoxamine. Now, the second drug is deferriprone, approved for use in 2011. Its route is oral, taken in 3 daily doses. The dose is 75 to 100 milligram per kg per day, 3 times a day. Now, interesting, it's effective in removing cardiac iron. Now, interesting advantage of deferriprone over deferoxamine is its ability to reduce cardiac iron levels, probably due to the small molecular size of this molecule and its lipophilic properties. Now, one study demonstrated that ventricular ejection fraction improved better as compared to deferoxamine. It undergoes extensive liver metabolism and greater than 85% recovered in urine as non-chelating O-glucuronide conjugate. Compliance rates are higher as compared to the deferoxamine. Now, the side effects of deferriprone: gastrointestinal like nausea, vomiting, abdominal pain, then neutropenia, granulocytosis. See, neutropenia occurs in 1 out of 15 to 20 patients, and agranulocytosis in 1 out of 150 to 200 patients. See, generally it is more frequent during the first year of treatment, sometimes reversible, but sometimes need to start therapy with GCS factor. Now, monitoring. What will monitor absolute neutrophil count ANC because of side effects of neutropenia and granulocytosis. ANC is monitored before starting treatment and then weekly. then monitoring to symptoms of arthropathy, liver function test, and ferritin. Now, the third drug is deferasirox. It's first widely used oral iron chelator in United States. Its route is oral, single daily dose. The dose is 20 to 30 milligram per kg per day. It can be taken empty stomach or with meals. If single dose is not well tolerated, then dose can be split and given twice daily. Has to be mixed with liquid before its consumption. Its chelation effects last all day. It protects cells from toxicity of non-transferrin bound serum iron and labile plasma iron also. It is safe and well tolerated in children, both in short and long-term periods. And it removes liver from both it removes iron from both liver and heart. Now, side effects of deferasirox: rash, which is usually transient; gastrointestinal upset, which often improves; kidney dysfunction, like elevated creatinine; Fanconi syndrome means low potassium, low phosphorus, acidosis; liver dysfunction, but no adverse effects so far on vision and hearing. Not know what will be monitored during this treatment. So kidney function test, KFT, kidney function test first 4 weeks after starting treatment, then after dose escalation, and then monthly. Urine protein, because proteinuria may occur during this treatment. Serum ferritin, if it falls below 1000, then dose can be reduced. If it falls below 500, then consider very low dose. Now, combination therapy. Why we are doing combination therapy? Intensities to maximize chelation intensity, then convenience to reduce the number of days of DFO with deferoxamine infusion. Efficacy, it access different iron pools, and good compliance. Now, combination therapy reduce ferritin level in patients in whom which monotherapy with deferriprone failed to produce satisfactory result. Now, combination chelation therapy explores weak chelator that penetrate cell better and strong chelators with effective urinary excretion. So it may result in improved therapeutic level. Now, the first combination is deferriprone plus deferasirox. Basic regimen: deferoxamine 20 to 40 milligram per kg, 3 to 5 days per week, and deferriprone 75 milligram per kg per day. So it can be used when chelation response is unsatisfactory, condition of serious cardiac side effects like cardiac cirrhosis, with or without heart failure, and conditions of high risk of mortality and morbidity. The second combination is deferasirox plus deferoxamine, suitable only for selected patients with very high iron burden, with cardiac iron load, with impending organ damage, then side effects from deferasirox like renal or gastrointestinal. Third combination is deferasirox plus deferriprone. So least experience so far, usually reserved when there is risk of organ injury or deferoxamine can't be used. Both drugs are taken daily. Deferasirox once daily and deferriprone 3 times a day. So this is all about the thalassemia and chelation therapy. Actually, I read this topic during my PG. I don't usually see such patients with sickle cell and thalassemia in my unit, but I tried to prepare. But if any points or any information I missed, kindly let me know, respected Dr. Jain ma'am and Kanikia ma'am. Thank you very much.
Thank you, Amol, for your wonderful and concise presentation. Swati, madam, expert, please come in.
I think you did a very good job, Dr. Ramon. There is really not much that I want to add. Just a couple of points that with deferasirox, it is a dispersible tablet and it is a chelator. So we do not disperse it in a steel glass or any metal glass. It has to be done in a kachka glass or otherwise in a plastic glass. And it has to be stirred also with a plastica spoon or a wooden spoon. You cannot use metal. Otherwise, it will get stuck to it and it will not be right. When you disperse it, we advise the parents that make sure that even the last bit of the dispersed tablet is actually mixed and given to the child. That's a very important practical point. Now what we have is Oleptis. This is a new, like you mentioned that deficiency has gastrointestinal symptoms. They are quite severe. In some patients, they will not take the drug because please understand that these kids are now growing up, they are working, they are professionals. And if they have repeated diarrheas, they cannot go to work or they cannot go to college or school. So one of the biggest problems with deficiency was the GI toxicity. Now they have come out with a film-coated deficiency, and this has really decreased the GI toxicity, the diarrhea in particular. It comes by the name of Jedano abroad, but it is available in India as Oleptis. I think, yeah, that was that, yeah. And it has, the other important thing with film coated is you can take it with a light breakfast as against deficiency, which has to be taken on an empty stomach. So for the children, it used to become very difficult. So these are just something new. Also, just to cover up a little bit, luspatercept is something which is kind of on the horizon. Let us see what, how things go forward. Like with voxelotor and trazanlizumab, we had a lot of disappointment. Patients were very sad because you're telling them that you have a potential life-changing drug and suddenly it's taken off the market. So let's wait with crossed fingers for luspatercept, which can really decrease the need for blood transfusions in thalassemia and potentially reduce the need for an iron chelator also.
Thank you, Swati madam, for your expert comments. I now request Sachin, Dr. Sachin Patil, to proceed further.
Thank you. Now the last topic is platelet transfusion, and the speaker for this is Dr. Snehal Patil ma'am from Kolhapur. Over to you, Snehal ma'am.
Yes, sir. Thank you, MAHAIAP team, for giving me this opportunity. I'll just share my screen. Am I able to see?
Yes, it is visible. Full screen.
Is able to see this slide?
Yes, yes, it is visible, but not full screen. Yes, yes, not full screen.
Make the full screen, ma'am.
Yes, I have done full screen, sir.
Double click.
Not possible. You are exited, I think. You again share, please. You have to share, ma'am.
Again share.
Yes. Start the slide view, ma'am.
Just double click on the screen. It will get full screen.
I'm not able to see this full screen.
No problem. Kindly continue. Kindly continue.
Okay. No, ma'am. Continue, ma'am. It's okay. Continue.
I'm not able to see the side. Now, okay?
Yeah. Yes, ma'am. You change the slides if possible. Change the slides.
Ma'am, use the arrow keys. Slide will change. Use the arrow key.
Arrow in from your laptop.
No, I'm not able to do that actually, sir.
Okay. Ma'am, kindly stop sharing. We'll share again once. Okay. Click on the share screen button. Where you will get two windows. One is with full screen and one is with your normal screen.
Yeah.
Select the full screen window.
Yeah. This one is like entire screen, right?
Yes, entire screen. Just select that and click on the share button.
Okay, I will share then. Not possible. Stop sharing. I will share, ma'am.
So just a minute. I'll just see once more.
Share.
Yes, you share only. I'm not able to see.
Double click to full screen. Double click.
Is it okay? Dr. Snail?
Yeah,
Are
yes,
you
sir.
seeing that?
Yes, yes.
Yes, it is visible now.
Yeah.
Okay. Yeah.
Okay. Good evening, everyone. I'll start with my presentation. Thank you, MAHAIP, for giving me this opportunity. As we know, these platelets are commonly transfused blood components in the many clinical settings, either therapeutically to manage the acute hemorrhage or prophylactically to prevent the bleeding. So, this platelet maintain the homeostasis by controlling hemorrhage after any blood vessel endothelial disruption. It involves the platelet adhesion, activation, aggregation to form the platelet plug at the site of injury. Next slide. So there are platelet products are manufactured by two ways. One is concentrated and pooled platelets from whole blood, or collector, or second one is collected directly from the donors via automated pheresis instrument. This platelet concentrated known as a random donor platelets, and apheresis platelet also known as a single donor platelets. Next. So pooled concentrates are advantages less costly. They are collected from the whole blood and easy to perform. But its disadvantages, they have the increased donor exposure. Donor matching is impractical, and they have higher RBC and WBC content. Apheresis platelet advantage is single donor platelet exposure. They have donor matching is possible, low RBC and WBC content, and they meet the leukoreduction criteria. But disadvantage is expensive. Collection requires the procedure of a operator and instruments, and is time consuming and less convenient for the donor. Next slide. So what are the indication in neonates? For preterm neonates with very severe thrombocytopenia, platelet count less than 25,000 platelets should be administered in addition to treating the underlying cause of thrombocytopenia. Next. In full-term neonates, in non-bleeding neonates, platelet transfusion should not be routinely administered if platelet count is more than 25. If it is in full-term also with less than 25, transfuse with no bleeding, transfuse the platelet. If platelet count less than 50,000 in neonates with bleeding or coagulopathy before surgery, need to transfuse the platelet. Or in any like fetal neonatal alloimmune thrombocytopenia, maintain the platelet count more than 30,000. Then are the indications for the platelet transfusion in infants and children during acute bleeding. In a non-immune thrombocytopenia, and even in patient with in severe bleeding, platelet count need to maintain more than about 50,000, along with the initial management of major hemorrhage. In patients with multiple traumatic brain injury, or spontaneous intracerebral hemorrhage, need to maintain the platelet count more than 1 lakh. Next slide. In immune thrombocytopenia, in ITP, or in post-transfusion purpura, we need to this intravenous immunoglobulin is a treatment of choice. Along with therapeutic blood platelet transfusion, need to give when there is a serious bleeding, and when we use this platelet transfusion prior to procedure or surgery when other treatment has failed or any other intervention is urgent. Next. In platelet function disorders, if any pharmaceutical therapies are contraindicated or ineffective, or there is a high risk of bleeding, they need to consider the transfusion of the platelets. Like in Glanzmann's thrombocythemia, we need to have the HLA matched platelet. Need to give this platelet. Then in drug-induced platelet function disorders, we do not need to platelet transfusion pre-procedure when these antiplatelet agents have not been discontinued. So we need to use the general hemostatic measures to treat the bleeding in patients during the treatment with aspirin or P2Y12 antagonist or glycoprotein 2A3B inhibitors. Next slide. So what are the indication for prophylactic platelet transfusion? In critically ill children, we need to use the platelet count threshold for reversible bone marrow failure for the prophylactic platelet transfusion. Like in dengue, we need to, if less than 10,000 in absence of bleeding, we need to transfuse the prophylactic, we need to give the prophylactic platelet transfusion along with the prolonged shock, coagulopathy, abnormal coagulogram with thrombocytopenia and hemorrhage. Next. In like autoimmune thrombocytopenia, there is no need of prophylactic platelet transfusion. But in irreversible bone marrow failure, or those receiving the intensive chemotherapy, or those are undergoing the hematopoietic stem cell transplant, need to give the prophylactic platelet transfusion to maintain the platelet count above 10,000. If it is like if these patients have additional risk of bleeding, we need to maintain the platelet count around 10 to 20,000 also. Next slide. In chronic bone marrow failure, there is no role of prophylactic platelet transfusion in asymptomatic patients. Next. So any prior procedures or surgery, should be a platelet count threshold, like venous central line insertion with ultrasound guided. Platelet count should be more than 20,000. In lumbar puncture, platelet count should be more than 40,000. Insertion or removal of epidural catheter, platelet count should be at least 80 or more than 80,000. In major surgery, platelet count should be 50,000. In neurosurgery or ophthalmic surgery, platelet or in which involves the posterior segment of the eye, need to have the platelet count more than 1 lakh. And percutaneous liver biopsy, this platelet need to have the platelet count more than 50,000. Next. So these are the different guidelines which have given the platelet. Given the prophylactic platelet transfusion threshold according to these different guidelines. It's almost the same. Next slide. So what is the dose and rate of platelet transfusion? Typical dose is volume is 10 to 12 ml of kg for more less than 15 kg, and more than 15 kg, one pack of platelet can be given. Transfusion is 10 to 12 ml per kg per hour, and all transfusion should be given via via the sets contain via blood administration sets containing microaggregate filters or bedside leukocyte reduction filter. And there is no other medications or fluids other than normal saline should be simultaneously given through the same line. And we need to monitor the signs of transfusion reactions, including vitals during during and post transfusions. Next slide. So there is a different like up to 15 kg we can give one platelet concentration which around 30 to 50 ml. In 15 to 30 kg, 2 platelet concentrate can given which is around 60 to 100 ml, and more than 30 kg, 4 platelet concentration can given which is around 120 to 400 ml. We need to transfuse platelet immediately on receiving the platelet concentrate, and don't need to refrigerate that. Next. So what are the contraindication of platelet transfusion? In patients with thrombotic microangiopathy, only you need to only this life-threatening bleeding, we need to transfuse the platelets. So how to avoid or manage the risk of platelet transfusion? The hospital should establish a strategy to maximize the transfusion of ABU compatible platelets, those who are requiring the regular platelet support. In ABU RH matched platelets should be given whenever available. Next slide. Next slide. So whenever this RH negative girls or women of childbearing potential should receive RH negative platelets. If it is not available, RH positive platelets can be given with anti-D prophylaxis. And with RH negative boys under 18 years, we can give the RH negative. If it is not available, we can give RH positive platelet also. Anti-D prophylaxis is not required in that patients. Next slide. So these platelets have increased risk of significant bacterial contamination or sepsis compared to other blood products, because platelet, they are stored in the room temperature because they rapidly lose the function when refrigerated. So there is a risk of sepsis with platelet transfusion is thought to be at least 1:50,000, and the risk of fetal septic platelet transfusion reaction is thought to be at least 1 in 5 lakh. So this bacterial contamination is more commonly caused by gram-positive clean flora as Staphylococcus species, but septic reactions can be due to either gram-positive or gram-negative organisms contamination. These are the different ways. Thank you. Different references I have used. So thank you.
Thank you, Snehal ma'am. Swati ma'am, will you want to add anything?
Yeah, so I think it was a very comprehensive presentation. Just a couple of quick points, if you allow me. When we talk about group matched platelets, check with your institute what they are using in the platelets. Like we use what is called as the platelet additive solution, or PAS, which you mentioned as your third point. Now, when you use PAS, you remove almost all of the plasma. And if the plasma is removed, there are no red cells, there are no antibodies in the plasma. And therefore, we are able to give platelets which are not group specific. for both SDP as well as for RDP, we are able to do that because of using fast solution. So even for the pooled RDP, we are able to do that. Also, you did mention about liver biopsy, and you said that platelet count of 50,000. So here, I'm going to tell you a very practical point. Even if your platelet count is 1 lakh, please look at the PT and PTTK. Please remember, you are doing a platelet, you're doing a liver biopsy in a child who has a defective liver. So if the PT-PTTK are prolonged, okay, and you're looking only at the platelet count, the child will bleed. So that is very, very essential. Also, as far as the dose is concerned, this is how I remember it. I don't know how easy it is for you, but 1 unit per 10 kg. Please just think about 1 unit of RDP per kg, okay, will per 10 kg will increase the platelet count by 50,000.
Yes.
So just that as a, then you can work further. And platelets, you said that once you receive them, don't refrigerate. Idea is not to refrigerate because the platelets will lose all their efficacy. In fact, when you tell your patients or parents to get platelets and blood together from the blood bank, so the RBCs are at a lower temperature. Platelets are at room temperature. Ask them to carry it in 2 separate bags. Sometimes the staff will just put it in the fridge, so they are not supposed to put it in the fridge at all. So just those couple of points.
Thank you, Swati ma'am, for useful tips in day-to-day practice. I think Dipti ma'am is not there. Minas sir, do you want to add anything?
Yeah, I think, at the outset, I will apologize our experts for being too late.
Yeah.
This is the longest session that we had, 15 past 11. However, at the same time, we appreciate, madam, that, most of our speakers are, they are young and they are doing, their slides were, presentations were very good. Content was very good. So in due course of time, they will also do better. Otherwise, the all 5 contents were excellent. It's only time management that we have to learn in due course of time. So thank you, Swati madam, and thank you, Deepti madam. Both have been my teachers and very good human being.
Thank you. Now
Thank you for inviting me. And yeah, I thought it was a very good session, a very good initiative.
Thank you, ma'am. Now I request Dr. Jaya Shivalkar ma'am for the vote of thanks.
Yes, it was a long session, but it's an informative session. And I must thank Dr. Sanjay Pakure and Dr. chance to hear the presenters also and on different topics also. And of course, today's experts, Dr. Dipti Jain madam, Dr. Swati Kanakia madam, for their expert comments and being here for so long. Thank you so much, madam. Our speakers for today, Dr. Anasaheb Lokande, Prasad Dharm, Dr. Amol Karangade, Dr. Shraddha and Dr. Nehal. Excellent presentations and a lot of efforts you all. Thank you so much. And Dr. Ravindra Sonowani sir and Dr. Patil for smooth conduct. Thank you for giving me this opportunity as a president of Open Committee here. Thank you.
Thank you.
Participant here for so long. Technical support for
Thank you.
Thank you, madam.
Thank you.
Swati madam, thank